Thank God I have my laptop. Okay, we're gonna get going so we can eat lunch. My name is Kathleen Hadsell and I'll be presenting on vestibular function and motion sickness today. Here is an outline of what my presentation will consist of. For time's sake, I'll skip it. So what is motion sickness? So we know that motion sickness can be experienced through body movement, like when you're on a roller coaster, through a sensory mismatch, so like being in a car, our eyes can see the scenery moving, telling our brain we're moving, and then our vestibular system is saying, hey, I'm sitting still. And then we can also experience motion sickness through virtual reality goggles and also through 3D movies at the theater. Some symptoms of motion sickness include nausea, vomiting, drowsiness, cold sweats, headaches, and increased salivation. So thinking about traveling on a plane, you may have been experiencing motion sickness if you feel fatigue or a headache. You might not have nausea, so that's kind of an interesting takeaway from that. So let's take a look at what body structures may be involved in causing motion sickness. On the top right, we see the vestibular system, and that is comprised of 5 peripheral organs. We have 3 semicircular canals, and these canals sense angular acceleration and where your head is in space. And then 2 otolith organs are the utricle and saccule. These sense vertical and horizontal acceleration, so driving in a car, and then vertical would be like jumping up and down. Then the vestibular ocular reflex is connected to the vestibular system, and that is shown with the circles in the back would be the semicircular canals. This keeps vision steady while our head is in motion. So thinking about jogging, your world isn't bouncing around. You can fixate on a tree as your body is moving. So what causes motion sickness, and what are some theories in past research looking at motion sickness? I want to point out that there's still only theories. So we don't know what causes motion sickness for sure, and that's a huge part of why I'm looking into this. So the sensory rearrangement theory is very popular, and that's just that mismatch in what our eyes are telling us and what our vestibular system is telling us. There's the otolith organ asymmetry, otoconia asymmetry theory, and then the area postrema in the brain might be the area that's kind of causing the symptoms for motion sickness. Past research has looked at VNG, caloric, VEMPs, and all of this has kind of been inconclusive. Some research, they find that people more susceptible to motion sickness have more robust responses, but other research doesn't find a correlation with that. Research has looked at when motion sickness kind of peaks or is the worst throughout our lives, and they say it peaks around age 10, theoretically, and should decrease with age. So the older we get, the less motion sickness we will experience. And that could be due to, as we age, a reduction in vestibular hair cells and a reduction in the vestibular nerve fibers. Also, research has found that VEMP amplitudes decrease with age due to the decreased in anatomical cells and fibers. And then it's interesting, a lot of the research, they all agree that you must have a vestibular system to experience motion sickness. You don't necessarily have to have eyesight, so there has been studies with blind participants who still get motion sick. So why study this? Again, it's an unclear pathogenesis. The effects are very debilitating, especially to some people. We need to know the mechanism involved in motion sickness before we can start looking at treatments for this. And we should look at the progression of motion sickness as we age because this is unknown. The purpose is to determine if individual differences in the vestibular function contribute to susceptibility of motion sickness, and to determine if motion sickness susceptibility decreases as we age. I have 2 hypotheses. So the first one is Individuals who are susceptible to motion sickness will have more robust responses in vestibular testing compared to people who are not as susceptible to motion sickness. And as age increases, susceptibility to motion sickness will decrease due to the natural decrease in the number of vestibular hair cells and neuron fibers. So for my participants, I recruited them by word of mouth, flyers in Goodnight Hall, and through the Institute on Aging. The inclusion criteria was they were healthy, 18 to 80 years old. The young participants would be grouped from age 18 to 54, and the older would be grouped from 55 to 80. They had to have normal middle ear function and normal thresholds greater than or equal to 20 dBHL across 250 to 8,000 hertz. However, through my study, I had to allow a mild sensory neural high frequency hearing loss to get enough older participants in my study, and no medications affecting the vestibular system. So I had 19 total participants, and here you can see I broke it down from gender and kind of young group and older group. I'm also using Maggie's data from last year. She just had normal young participants, and she had 21. So 40 total participants will be reflected in my graphs later on in the talk. My procedures, I started with a case history. We did a middle ear assessment with tympanograms, acoustic reflexes, moving on to audiometry, pure tone thresholds. I administered the motion sickness susceptibility questionnaire and the MoCA, which is the Montreal Cognitive Assessment. We did vestibular evoked myogenic potentials, both the C-VEMP and the O-VEMP, to get the whole picture of the vestibular system, and video nystagmography, which included oculomotor testing and caloric testing. And here's a picture of the motion sickness susceptibility questionnaire. It asked the participant to rate the level of motion sickness they experienced before age 12 and in the past 10 years, and rate it in level of severity and the types, as you can see, cars, aircrafts, all the different types of transportation. For VEMP testing, C-VEMP testing, that is a picture of what it looks like, the electrode placement. C-VEMP tests the function of the saccule, so vertical acceleration. And it also tests the function of the inferior vestibular nerve. We used a 500 hertz Blackman gated tone burst, and we looked at the peak-to-peak amplitude and latencies. The O-VEMP testing, we're just moving some of the electrodes up to the face for this. It's measuring the function of the utricle, and that is horizontal acceleration again, and the function of the superior vestibular nerve. And we're putting a bilateral low frequency tone burst into both ears during this test. This is a picture of a really beautiful C-VEMP wave. We're looking for a positive peak at 13 milliseconds and a negative peak at 23 milliseconds. And this smiley face would tell the participant if they're kind of contracting their sternocleidomastoid muscle well enough for the measurement to be made. Also, the O-VEMP wave is similar looking to C-VEMP, but we're going to see a negative peak around 10 milliseconds and a positive peak around 15. So it's shorter, and it starts with negative to positive. Next, moving on to oculomotor testing, we did gaze, saccade, smooth pursuit, optokinetics. For all of these tests, the participants wearing goggles, and we're tracking their eye movements as they follow a red dot on a light bar. We're measuring the accuracy, so the ability for them to follow the light with their eyes, the latency, so lag versus lead of the eye movements to the light, and the velocity, so the eye speed compared to the light speed. For caloric testing, we're measuring the function of the horizontal semicircular canal. So just one of those semicircular canals. I only did warm irrigations right and left. The warm really increases the nerve firing rate. So we're looking for hypofunction. So the assessment is looking at the slow phase velocity of the nystagmus. So once water is placed into the ear, the eyes will start to beat towards the ear being stimulated, and we measure the eye beating. So the degree of visual fixation suppression is also very important in this test. In a point of the test, a red dot will come on in their goggles, and they're asked to stare at the light. And as they fixate and stare at the light, their eye beating should decrease. So my results, this is a graph of the MSSQ motion sickness questionnaire raw scores on the x-axis versus the MSSQ percentile score on the y. And as you can see, I have a great spread of some people on the very right are very susceptible to motion sickness, and people on the left don't really experience motion sickness. Young participants are the blue dots, and my older group is the orange triangles. And some of them are overlapped, so it's hard to see. Looking at the motion sickness susceptibility questionnaire further, that questionnaire breaks the scores down into MSA, which is the blue bars, and that reflects how motion sick they felt 12 years and younger, so in the beginning of their life. And then MSB reflects how motion sick they've been now and in the past 10 years, so later on in their life. And for my young group, we see that the susceptibility didn't really change much throughout the years, and same for the older group. However, the old group did report being less motion sick than the young group overall. The VNG results, we're looking at the MSSQ score versus the saccade peak velocity. So we're averaging the right and the left saccades. The young is the blue dots and the old is the orange triangle. And there was not a significant correlation between these two. It's variable, and my trend line is pretty horizontal here. The caloric results, we're looking at the MSSQ versus the warm slow phase velocity. I've separated out the ears, and I've separated out the age groups. And we found a statistically significant correlation between the young left ears and the motion sickness scores. So that was interesting. It was just the left ear. Looking at the visual suppression results in the caloric testing, I have Maggie's trend graph from last year, and there was a positive statistical significance between these two things. And in my graph, again, we're seeing the young left ear being statistically significant. So the more motion sick they say they experience, the less they're able to slow those eye beatings down. So the higher the visual fixation index, the faster their eyes still beat when they're trying to stare. So for the VEMP results, we're looking at the MSSQ percentile scores versus the right and left mean of trial 1 and 2 for the peak-to-peak amplitudes. And again, we're not seeing any statistical significance between these two. Same with the OVEMP. There's not a lot of statistical significance, but we're starting to see that positive trend line. Maybe with more subjects, that would be a little nicer looking. So again, on the X, we have MSSQ percentile scores versus the OVEMP mean of the right and left amplitudes. So overall, there is a large variability in my collected data, as we saw. However, it's interesting that older participants' responses were consistently under my trend lines. It's kind of agreeing with the theory that as we age, our systems are less robust. Older participants reported being less motion sick on average than younger participants, and there was no change seen in motion sickness susceptibility within young and old groups from past to present. Limitations and future directions. So limitation is a small sample size, and I really need more older participants, 55 and older, for really comparing these results further. We might want to look at a more sensitive questionnaire to assessing the susceptibility to motion sickness. Some of my participants, especially with fun fair rides question, they said, well, when I look at the ride, I really have a hard time, I get sick, but if I'm on the ride, I don't get as sick. So there's variability in these questions, and it's hard to really tease out how motion sick these people are getting. We need to try to shorten the protocol for the older adults, and that is one reason why we only did the warm calorics. We did right and left, but just warm calorics instead of cold too. And it would be cool to do a longitudinal study and maybe retest the same subjects throughout the years to see how their vestibular system is aging. Here are my references, and a huge thank you to Dr. Fowler, Dr. Lee, and Dr. Henning for helping me through this journey. Everyone who participated in my Capstone study, I had a lot of you all participate. Thank you so much. Excel support, Bryce Hadsell and Dr. Fowler, a quick and dirty rundown of how to do graphs in Excel. And a thank you to my parents for not only being participants, but being here today. Any questions? Yeah.
I think it's really interesting the piece about the visual fixation being statistically significant, and I wonder if the theories about motion sickness and the fact that people who are older tend to have less of it suggest there's a central compensation component. Do you think that your results might be suggesting that? That there's less central compensation in younger individuals, and that's why people, when they age, are less susceptible to motion sickness?
That could very well be. Again, I really need more older adults to really see that. I had 2 participants who reported not really ever being motion sick, and they had very robust results. So again, I think I just need more older participants to really tease that out.
Do you think older adults avoid situations where they know from past history they'd be, and so they don't report it because they've consciously...
Yeah, of course. And it's also interesting to think about, as a little kid, you're constantly on a swing and on roller coasters, and are you training your vestibular system as a kid to kind of get used to those motions? And then as you age, you're not doing that stuff. So if I hop on a swing now, I'm like, whoa, this is horrible. So our vestibular systems might not be as sensitive, but we're not doing those activities anymore. So it could feel worse, even though if you test their system, their decline in the responses.
This is coming from a totally naive point of view, because I haven't taken the balance class yet, but could there be something to do with how hair cells die off as we age too, like something with the vestibular hair cells?
Yes, so the number of hair cells and neurons and even the size of them decrease as we age. And that's not disease or anything, that's normal. So definitely. All right, thank you so much.